Thank you, sir, for including me in this course, and it's an honor to share the stage with such esteemed personalities. So, good afternoon, everyone. I'll be talking about idiopathic orbital inflammatory disease. The orbit is a Pandora's box because you don't know what you're going to get inside the orbit. And when talking about orbital inflammations can either be specific, which have a definite local or a systemic cause, or orbital inflammation can be non-specific, which is going to be covered here, which is also known as idiopathic orbital inflammation or orbital pseudotumor. So, idiopathic orbital inflammation is a benign, non-infective, inflammatory condition of the orbit which does not have any local or systemic cause identifiable. It is also known previously as pseudotumor, and it is the third most common orbital disease. So, anyone dealing with the orbit and even the pathologist must be aware of this entity. And the prevalence is most common in third to fifth decade. The disease is mostly unilateral but can also be bilateral. These are the 5 signs of inflammation that all of us have studied. So, keeping this in mind, the presenting features of IOID can be varied ranging from orbital pain to a mass, diplopia, proptosis, limitation of motility. Then, if the posterior orbit is affected, decrease in vision, neuropathy, and inflammation can be acute or subacute, but it is also important to understand and remember that inflammation is also chronic. This is the classification of IOID based on the onset, and according to the structures that might be affected in IOID, it can be classified as anterior, posterior, apical or diffuse IOID. So when the lacrimal gland is affected, it is dacryoadenitis. Sometimes isolated muscles or multiple muscles can be affected, known as myositis. Then if the sclera is affected, it is scleritis. Then the optic nerve or the optic nerve sheath can be affected in perineuritis. There can be isolated orbital masses. There can be apical involvement, or it can be a diffuse IOID. So radiologically, these are the different features of IOID. I'm going to move forward from here. This is the histopathological classification of IOID. It can either be a classic chronic inflammation, granulomatous variety, or sclerosing variety, which has fibrosis and sclerosis. So we're going to go through some interesting and atypical cases of idiopathic orbital inflammation. This is a 47-year-old female who has a right eye swelling and fullness, which can be seen. Has history of pain, but there is no systemic history. And if you see, the duration is 6 months. So as I said, it is important to remember that inflammation can be chronic also. So on imaging, she has bilateral enlargement, homogeneous enlargement of the lacrimal gland, right side more than left side. And when biopsy was performed from the right orbital lobe, it was seen that there was chronic non-specific inflammation, some interlobular fibrosis, and positivity for IgG4 cells. So she underwent extensive rheumatological workup, all of which turned out negative even for IgG4. And after receiving 3 pulse doses of steroids, you can see the proptosis has gone down, the ptosis has improved, and she's on regular follow-up now. This is another interesting case of a 9-year-old female who presented with right eye cataract with a retrolental membrane, which was painful, and there was a dubious history of trauma. There was no other important relevant history. And when B scan was performed, the B scan was normal, but if you look at the ultrasound biomicroscopy, you can see infiltration of the iris and the ciliary body and a mass lesion sitting there. So in view of the mass lesion, further imaging was performed. The MRI is not very representative here, but there was a ciliary body swelling, and a probable diagnosis of medulloepithelioma was kept, and the eye was enucleated. But on the enucleated eyeball specimen, surprisingly, a dense inflammatory infiltrate was noted, which was involving the iris as well as ciliary body, with a lot of lymphocytes and plasma cells. So multiple diagnoses were kept in mind. IgG4 was again considered along with xanthogranuloma, but the serum and tissue IgG4 levels were low and markers for histiocytes were negative. There were no macrophages also to support xanthogranuloma. So a final diagnosis of intraocular IOID was made, and no further treatment was done for this patient. This young male presented with swelling and fullness in the left upper eyelid, which can be seen, which progressively increased in size. And probable diagnosis of epidermoid cyst was kept in mind. This lesion was debulked, but on histopathology, again, a very rich lymphocytic infiltrate was noted. And IHC panel showed a polyclonal nature of the infiltrate. This patient received systemic steroid and there was complete resolution. This is another interesting case of a 9-year-old girl who had acute painful diplopia. And if you see, her elevation is restricted in the right eye, but there are no signs of inflammation here. On imaging, there was a diffuse enlargement of the inferior rectus, which can be seen. It was irregular and the tendon was also thickened. This patient again received systemic steroids, and you can see the diplopia improved and the elevation has also improved here. Another case of a child who presented with reduced vision, and on the fundus examination there was disc edema. On the external photo you can see there is congestion, ptosis and a mild proptosis also. The eye movements were very painful. Imaging revealed some sort of thickening near the sclera, which can be seen there and along the optic nerve. This patient again received systemic steroids and improved with systemic steroids. So a probable diagnosis of apical neuritis was made. This gentleman presented with a painful proptosis in the left eye. You can see there is skin puckering there inferiorly in the left eye, and there is limitation of extraocular movement. Unfortunately, I don't have imaging for this patient, but a biopsy was performed from the swelling in the inferior eyelid, and a paucicellular infiltrate with a lot of extensive fibrosis came out, which is characteristic for sclerosing NSOID. This patient again received steroids and did well. So the pathogenesis of IOID is still unknown mainly. There are two major theories. One is the viral infection theory and one is the autoimmune theory. And there is evidence in literature to support that. But histopathology is important, and the decision whether or not to do the biopsy depends on the site of the presentation and the imaging findings. And histopathology will invariably reveal chronic inflammation with lymphocytes, plasma cells, eosinophils, and varying degrees of fibrosis. Sometimes granulation or IgG4 positive cells may be noted. But the most important thing is that the proliferation is always polyclonal. So when dealing with the orbital IOIDs, there are some important differential diagnoses that need to be kept in mind. An important one is lymphoma. So clinically, lymphoma is going to be painless, usually presenting in the older age group, and on imaging you will see molding of the swelling around the globe. And when you do histopathology, monoclonal proliferation will be seen. Then thyroid eye disease is another very close differential for IOID. But unlike IOID, thyroid usually has a chronic presentation, and the patient may have history of thyroid disorder also. There will be lid signs, external signs. Apart from that, when you perform imaging, unlike IOID, there will be tendon sparing muscle enlargement, which is known as the Coca-Cola sign. And you'll also see orbital fat enlargement. Orbital cellulitis is one more important differential diagnosis, which will present with pain, but there will be systemic symptoms also, such as fever. You might identify a source of infection, especially the sinuses, which are the most common route of spread to the orbit. Then in children, differential diagnosis of dermoid rhabdomyosarcoma and lymphangioma. These are the three things that need to be kept in mind. Again, radiology and histopathology will guide us towards the diagnosis. For management of IOID, systemic steroids are the first line of management. They have a very fast onset, give a very good response. But it is important to remember that IOID may recur after steroid withdrawal, and the patient need to be counseled about that. Immunosuppressants form the second line of management. These are steroid sparing, and patients who might not be responding very well to steroids may be started on immunosuppressants. Orbital radiotherapy is another management option in patients who are refractory or intolerant to steroids. 20 gray is the usual dose which is given over 10 days to patients, and a good response is seen in the short term, but radiotherapy of course has complications in the long term. So the management line, if you see typical features of IOID which have been discussed, if it's the first episode unilateral disease without any systemic involvement, The patient can be given a trial of low-dose steroids. Usually the prognosis is good in such patients and recurrence remains unlikely. But if disease is bilateral or recurrent or there is apical involvement, the patient definitely needs a high dose of steroids, may also need immunosuppressants. And such patients need to be investigated systemically because there are a lot of differential diagnoses for this condition and a close follow-up should be maintained. Biopsy can be performed for anterior lesions. And when the patient has atypical presentations, such as the last case we saw, and patients having sclerosing NSOID, again biopsy will confirm the diagnosis and the specific disease needs to be treated. So the prognosis is generally good for IOID. It is considered a self-limiting condition by many people. And the primary goal in IOID remains control of inflammation in the acute stage and avoiding any long-term complications. And steroids can be started for the acute phase followed by slow tapering. Usually a good prognosis is seen in this condition, but the patient still needs to be counseled for recurrences, especially when multiple muscles are involved. So thank you.
Thank you, Dr. Ubaid, for a wonderful presentation. Any short question to Ubaid? We have 3 minutes time. Any question? Bhagyashari Madam, Soumya, any question to Ubaid? Can you speak on the mic?
So we often encounter IOID as granulomatous inflammation. Will that be just a diagnosis of exclusion of all the infectious diseases, or we have to find something else in that?
So IOID is a diagnosis of exclusion because you have to rule out all the mimicking conditions. Granulomatous inflammation usually does not fall under IOID because there are a different set of conditions such as sarcoidosis or maybe tuberculosis, which will present with granulomatous inflammation. So if you find granulomatous inflammation, it is better to investigate the patient systemically. Also, it will depend on what are the imaging features, what is the clinical presentation of the patient.
Well, I like to add, if you see a diagnosis IOID for pathologists, only a GMS, GIS, tissue gram stain, and AFB must be done, okay, to tell that it is a IOID. And the CD3, CD20 or CD138 for plasma cells and the IgG4. So this question is very relevant. As a pathologist, she's asking on the pathologist point of view. Here we have to do GMS for fungus, we have to do tissue gram stain, and we have to do a AFB stain to tell that it is a IOID.